Hello friends, welcome to a new topic today. In this chapter, let us now learn about the pharmacology. In the pharmacology, we will learn about the sympathetic nervous system. Okay, so in the sympathetic nervous system, we have two important hormones which are helpful in sympathetic nervous system, which include noradrenaline and adrenaline. Okay, noradrenaline is a neurotransmitter, whereas adrenaline is a hormone which is synthesized or secreted in response to stress. So stress will activate synthesis of this hormone. Actually, stress will activate the adrenal medulla, and from this adrenal medulla, this aldosterone is actually synthesized. Okay, so once you have learned about this synthesis of this adrenaline, okay, sympathetic nervous system. Now what do we have to learn? So first we will see the receptors of the adrenergic system. These include, we have two different types of receptors. We have alpha receptors and we have beta receptors. Okay, so these alpha receptors are again of two types. One we have alpha 1, second we have alpha 2. These beta are of three types. We have beta 1, beta 2 and beta 3. Okay, so where are these alpha 1, alpha 2, beta 1, beta 2, beta 3 are present? So if you see alpha 1, this alpha 1 is present in blood vessels. Okay, because they are present, see, okay, so alpha 1, it is present one in blood vessels and it causes vasoconstriction. Okay, then it is present in genitourinary smooth muscles, and this causes vasoconstriction of these smooth muscles. Okay, the contraction of the smooth muscles. It is also present in prostate. So this is the prostate, and what does this cause? This also causes contraction of prostate. Okay, it is present in eyes. In the eyes we have two types of muscles. We have the ciliary muscles and we also have the radial muscles. Okay, what does this cause? This causes contraction of these radial muscles. Okay, once there is contraction of these radial muscles, there is mydriasis of the eye occurs. Okay, it helps in mydriasis. In the gut, this alpha 1, in the gut, in this gut it causes relaxation of the gut. In the glands, it causes relaxation and retention of secretions in the glands. Okay, then what about next? Alpha 2. Alpha 2 is actually a presynaptic receptor. What does this mean? This is the synapse. If you see, alpha 1 is present here, but alpha 2 is present in presynaptic area, and as a result, what does this alpha 2 do? What does alpha 1 do? Alpha 1 will act, noradrenaline which is released, it acts on alpha 1. Okay, so this noradrenaline also acts on alpha 2. Okay, what does this alpha 2 do? Alpha 2 will inhibit this release of noradrenaline from the synapse. Okay, so that is main thing of alpha 2. Alpha 2 inhibits the release of noradrenaline. Okay, so this alpha 2 is secreted by beta cells of pancreas, and once it is secreted by beta cells of pancreas, this will decrease the insulin release. It is also seen in adipose tissue and it causes lipolysis. It results in lipolysis. Okay, then this is a GI type of adenyl cyclase receptor. Then we have beta 1. So if you see beta 1, where is it present? It is present in heart. It is actually activating everything in the heart. So because it is activating the chronotropic effect, if it has a chronotropic effect, it increases the heart rate. It has inotropic effect, so it increases the force of contraction. It has dronotropic effect. What does dronotropic effect do? This dronotropic effect is that it will increase the rate of conduction of the impulses, and as a result increases the conduction velocity. It also, because it increases the conduction velocity, it decreases the refractory period. Okay, so this is GS and it is adenyl cyclase receptor. And if you see, this beta receptor is also present in kidney. In the kidney, it acts on GJ cells and lead to release of renin. Okay, so that is beta 1 action. Then what does the next receptor? Beta 2. Beta 2, it is present in lungs and it is causes bronchodilation. Okay, then it is present in the urinary tract, okay, that too in this detrusor muscle part, and it causes relaxation of the detrusor muscle. Then it causes in the uterus, okay, it causes relaxation of the uterus, beta 2 only. It is present in the uterus and causes relaxation of the uterus. It is also present in splenic capsule also. Even here it causes relaxation of splenic capsule. Then it presents in the skeletal muscles. Because it presents in the skeletal muscles, it causes tremors. Okay, so these are the different things that occur, important parts of beta 2. Then what about beta 3? Beta 3 is present in adipocytes. And what does this do? This causes lipolysis. Okay, now these are the alpha 1, alpha 2, alpha 3, beta 1, beta 2 receptors. Along with that, we have one more type of receptors which are important, which are called as dopamine receptors. We have dopamine 1 receptors which are present in kidney and also coronary blood vessels. So in both these it causes vasodilation, whereas it is present in the myocardium, okay, and it increases the force of contraction. It is also present in the brain, okay. So these are the receptors, these are the places where dopamine DA1 is present. It is GS type of receptors. We have dopamine 2 also, DA2 receptor, which is present in CNS, especially basal ganglia, and decrease the noradrenaline release. It decreases the noradrenaline release, okay. Then, so if you remember, we have double actions in many organs, okay. See, let me summarize. See, in the blood vessels, if you see, in the blood vessels, if you remember, alpha 1 causes vasoconstriction, whereas beta 2 causes vasodilation. What will you see? What do you think? Will there be vasoconstriction or will there be vasodilation? This depends mainly on the dosage. So if you see this alpha 1, see, there is something called as vasomotor uh, Dale vasomotor reversal. That's not important. See, alpha 1 is activated, the BP recording if you do for any adrenaline or non-adrenaline, any sympathomimetic drug, you see that at first there is increase in blood pressure because of vasoconstriction. Later there is decrease in blood pressure because of vasodilation. Why? In the beginning, at lower concentration, okay, alpha 1 receptors will get activated. At higher concentration, sorry, at higher, I'm really sorry, at higher concentration, alpha 1 receptors get activated. At lower concentration, beta 2 receptors get activated. Initially, there will be higher concentration, so alpha 1 gets activated. As the concentration decreases, beta 2 gets activated, resulting in vasodilation. So it depends upon dosage. Then what about the skin or mucosal or splanchnic muscles? In them, there is alpha 1 predominance is present. Then, if we see in the skin muscle and splanchnic splanchnic blood vessels, there is alpha 1 predominance. Because of alpha 1 predominance, there is vasoconstriction. Then, if you see, there are in the skeletal muscles and in the coronaries, if you see, in them, there is beta 2 predominant. Obviously, right? Because in skeletal muscles, whenever you do exercise, there should be increased blood flow to the skeletal muscles during exercise. So for that there should be vasodilation. So obviously in them there is beta 2 predominance. Whereas if you see in the renal vessels, if there is alpha 1, it causes vasoconstriction. If there is D1, it causes vasodilation in the renal vessels. So sympathetic stimulation less increases in vascular resistance in renal vessels than in others. Okay, so this is important. So now let us learn about the drugs which are called as sympathomimetic drugs. So what are the sympathomimetic drugs? Okay, sympathomimetic drugs can be divided into two types. They are divided into two types. One, we have directly acting. In the directly acting, we have two more types of directly acting sympathomimetics, which include we have catecholamines and we have non-catecholamines. In the catecholamines, we have adrenaline, then we have noradrenaline, and then we have the dopamine, whereas in non-catecholamines we have, sorry, in catecholamines these are the ones which are secreted in our body, so they are endogenous type of catecholamines. We have exogenous also. Exogenous are those which we give our body, so these include dobutamine, dopamine. Then we have phenoldiazepam. These include dobutamine, dopamine, phenoldiazepam, and isoprenaline. Okay, these are the exogenous catecholamines. Then we have non-catecholamines. Non-catecholamines include xylometazoline. Then we have clonidine, phenylephrine, okay, salbutamol, methoxamine. Okay, so these are non-catecholamines, okay, which are directly acting. We have indirectly acting sympathomimetics also. So in the indirectly acting sympathomimetics, we have two different types. One, we have reuptake inhibitors, and we have those which we get through displacement reactions. Reuptake inhibitors are tricyclic antidepressants, uh, noradrenaline reuptake inhibitors, serotonin noradrenaline reuptake inhibitors, and these displacement reactions include mainly tyramine, okay, ephedrine, then we have pseudoephedrine, and then amphetamine and methamphetamine. So in the displacement reactions, we have tyramine, ephedrine, pseudoephedrine, amphetamine, and methamphetamine. So these are the different drugs which you see in displacement reactions. So we will learn about directly acting sympathomimetics first. So in the directly acting sympathomimetics, the first one which is important is about epinephrine. So in the epinephrine, we have beta 2 action is predominant, then beta 1, and all the others beta 1, alpha 2, alpha 1 are almost equal. So if you see, because it has beta 2 predominance is present, so what is its action on different systems, we will see. So if you see on CVS first, CVS, it causes in systolic blood pressure is mainly dependent on beta 1. Diastolic blood pressure is dependent on all beta 2, on both beta 2 and alpha 1, whereas heart rate is mainly a reflex action here. So here systolic blood pressure is present on beta 1. So here beta 1 is present and there is increased systolic blood pressure. And diastolic blood pressure is dependent on beta 2 and alpha 1. Here, if you see this diastolic blood pressure, it is present both on beta 2 and alpha 1. What does beta 2 do? Beta 2 causes vasodilatation. What does alpha 1 do? Alpha 1 causes vasoconstriction. So as a result, there should be increase in BP in vasoconstriction due to alpha 1. There should be decrease in BP due to beta 2. Then which predominates? As I have already said, it depends upon the dosage. This mainly depends upon the dosage. So if you see, in diastolic blood pressure, there is no action reflexly because there is increased heart rate. So let me show you. There is something called as how is the response if this is a person and he has baseline of 120 blood pressure and you have given epinephrine. So once you have given epinephrine, then you'll see this biphasic reaction. We have something called as biphasic reaction. So in this biphasic reaction, first there will be alpha 1 action followed by beta 2 action. Why is first alpha 1 action? Why is first alpha 1 action? Alpha 1 action is present because of, okay, this alpha 1 action is mainly because of at higher doses. See, at the higher doses of drug doses, the alpha 1 action is first activated, and as a result there is increased BP. As the dose decreases, that is at lower doses, there will be beta 2 action which is seen. So this is called as biphasic reaction. Imagine that this is the normal reaction which you see, but now imagine that you have given, um, imagine that this is the baseline BP, and now you have given epinephrine, obviously, okay, and along with epinephrine you have given alpha blocker. Because you have given alpha blocker, there won't be this response. There will be only the beta 2 action which you see. So this is obviously a uniphasic response, and here you have downward deflection, right? It is a unipolar response with downward deflection, and this is called as vasomotor reversal of Dale. This is called as vasomotor reversal of Dale. Okay, and there is one more thing, which is this is vasomotor reversal of Dale if you give alpha blocker, sorry. imagine that this is the normal BP, and now you have given epinephrine. Imagine you have given beta blocker instead of alpha blocker. Then how will the curve be? So there is beta blockage. So alpha action will occur. So as a result, there will be like this, and there is no beta action. So this is seen as, this is a uniphasic response. Okay, and this response is present with upward deflection. It is uniphasic response with upward deflection, and this is called as vasomotor re-reversal of Dale. Okay, this is called as vasomotor re-reversal of Dale. So this is important thing which you have to see in epinephrine, especially in the CVS. Now coming to lungs. In the lungs, if you see, in the lungs we have bronchi, right? In the bronchi there will be beta 2 receptors. These beta 2 receptors causes vasodilatation of bronchi. Sorry, not vasodilatation, sorry, bronchodilation of bronchi. Okay, so there is one thing which is asked very frequently, which is called as physiological antagonism. See, what is physiological antagonism? Two things or two drugs will act on two different receptors and they have opposite action. That means, for example, adrenaline will activate beta 2 and thus it causes bronchodilation. But if you see, if you give histamine, okay, this activates on H1 receptors which are also present on bronchi and they cause bronchoconstriction. Okay, so these two are acting on two different receptors and they are having correctly opposite action. So this is called as physiological antagonism. Okay, this you should remember. Then after that, the next important thing is about the urinary tract. Okay, in the urinary tract, if you see, this is the bladder, I'm sorry. Here this you have trigone. Okay, on the trigone you have alpha 1 receptor. Okay, so this alpha 1 increases the tone of this trigone. Okay, so this is important. Next, if you see, what about the uterus, the action on uterus? So this is the uterus. So in the uterus you have two things which is important. It depends whether she is a pregnant or non-pregnant. Okay, pregnant or non-pregnant. Think that if she is non-pregnant, then there will be alpha 1 more than beta 2 action. So thus there is contractions. In pregnant women, beta 2 action is more than alpha 1. So there is relaxation. Non-pregnant you see alpha 1 more than beta 2, so that causes contraction, whereas in pregnant women you see beta 2 more than alpha 1, so that causes relaxation. Okay, then in metabolic actions, if you see, first you will have to see in the liver. In the liver there will be gluconeogenesis occurs in the liver, and you see glycogenolysis. There will be gluconeogenesis and glycogenolysis occurs in the liver. Both these causes hyperglycemia. Gluconeogenesis or glycogenolysis occurs. Both these results in hypoglycemia. And if you see beta 3 receptors, these causes breakdown of adipose tissue leading to lipolysis. Whereas alpha 2, as I have already said, they have action on pancreas and they will decrease the insulin release. Okay, so these are the metabolic actions. Now once you have learned this, what are the uses of the epinephrine? Uses of epinephrine are very important. They are drug of choice in anaphylactic shock. They are the drug of choice, and if you see, they are given as IM 1 in 1000 adrenaline. So if you see, what does 1 in 1000 adrenaline mean? That means that you give 1 milligram in 1000 ml. Sorry, yeah, if you give 1 milligram in 1000 ml, you give 1 in 1000 adrenaline, 0.5 ml injection you will give. Sorry, this is not 1 milligram, 1 gram. So what is 1 in 1000 adrenaline mean? 1 in 1000 means you give 1 gram of adrenaline in 1000 ml of normal saline. So in such case, you will have 1 gram in 1000 ml. So that means you are having 1000 milligrams in 1000 ml, right? So if it is 1000 milligrams in 1000 ml NS, so if you are giving 0.5 ml injection, then in 0.5 ml injection you will have 0.5 milligrams. So you are giving 0.5 milligrams dosage in 0.5 ml injection. So that is what you give in MIM. Okay, then if there is no response, then you will have to repeat it. If there is no response again, then you will have to give IV solution 1 in 10,000. You have to give IV. Okay, so this is anaphylactic shock. Okay, then after this, this is anaphylactic shock. Then you have bronchial asthma. You can use it in bronchial asthma also. So in the bronchial asthma, you give inhalation of bronchial asthma. Inhalationally, you give 1 in 100. Okay, and then you can give it in cardiac arrest. Okay, in the cardiac arrest, you can give it IV, that is 1 in 1000. You can give in cardiac arrest, you can give IV, that is 1 in 1000. You can also give it in local anesthesia. In local anesthesia, you give subcutaneously, that is 1 in 2 lakhs. You give subcutaneously 1 in 2 lakhs in local anesthesia. In cardiac arrest, you give IV 1 in 1000. In bronchial asthma, you give inhalational 1 in 100. Again here IM also you give for anaphylactic shock, you give intramuscularly 1 in 1000 adrenaline. For anaphylactic shock, you give IV 1 in 10,000. In bronchial asthma, inhalational, you give 1 in 100. In cardiac arrest, you give IV 1 in 1000. To prolong the duration of local anesthetic, you give subcutaneously 1 in 2 lakhs. You can give adrenaline in epistaxis. You can also give it in pulseless cardiac arrest. Okay, the alternative to epinephrine here is vasopressin. You can also give vasopressin in pulseless cardiac arrest. Then after this adrenaline, then the next drug which is important here is noradrenaline. So in the noradrenaline, you have the actions of receptors are alpha 1, alpha 2 and beta 1 are the receptors which are used here. And what are the actions here? Here if you see, you have the following actions. In systolic blood pressure, as I have already said, beta 1 receptor is mainly responsible for systolic blood pressure. So obviously beta 1 receptor increases the heart force of conduction, thus increasing the systolic blood pressure. Whereas in diastolic blood pressure, it depends on alpha 1 and beta 2. But here there is no beta 2 action at all. So only there is alpha 1 action. So this causes vasoconstriction and increases diastolic blood pressure also. So whenever there is increase in diastolic blood pressure, okay, initially there is transient increase in heart rate, followed by, due to this reflex increase in blood pressure, there is decrease in heart rate, that is reflex bradycardia is seen. So if you see this noradrenaline is the drug of choice for septic shock. So remember that this noradrenaline is useful for septic shock. In transplanted heart, if you see, if there is a transplanted heart, in them there is no reflex action is seen in transplanted heart. This you should remember. Okay, so there is no reflex bradycardia is seen in transplanted heart. Then once you are done with this noradrenaline, then you should learn about dopamine. So in dopamine, if you see, we have three receptors. As I have said, dopamine acts on D1 receptor, D1 receptor, DBA, that is beta 1 receptor, alpha 1 receptor. Remember, it has DBA, which is dopamine, which see D instead of P, remember B and A. This looks like a part of B, right? DBA. So D receptor, D1 receptor and alpha 1 receptor. All these are ones. Okay. D1 is, it causes vasodilatation. Beta 1 increases heart rate, whereas alpha 1 causes vasoconstriction and thus increases BP. Right? So this action of dopamine is there in three receptors, and there is opposite action, especially in D1 and alpha 1 receptor. So it causes, so this action depends upon the dosage. So D1 receptors are activated at 1 to 2 microgram per kg per minute, and beta 1 are activated at 2 to 10 microgram per kg per minute, and alpha 1 are activated in more than 10 microgram per kg per minute. Okay, so D1 is activated by causing vasodilatation at 1 to 2 microgram per kg per minute. Beta 1 are activated causing increased heart rate at 2 to 10 microgram per minute. Alpha 1 are activated increasing BP at more than 10 microgram per kg per minute. So if you see, this dobutamine is drug of choice in cardiogenic shock with oliguric renal failure. Okay, these are the drug of choice in cardiogenic shock with oliguric renal failure. So what is the dose that is given in congestive heart failure? You give 2 to 10 microgram per kg per minute, because in congestive heart failure you will have to cause, or you will have to do something to increase the force of conduction on the heart. You will have to activate the heart. So for that you give action should be on beta 1 receptors. So you should give 2 to 10 micrograms per kg per minute. Okay, so this is dopamine. About dopamine, you have two receptors, D1, beta 1 and alpha 1. D1 acts on, D1 causes vasodilatation causing 1 to 2 microgram per kg per minute. Beta 1 increases heart rate, so the dose at which it is activated is 2 to 10 microgram per kg per minute. Alpha 1 causes vasoconstriction, the dose at which it is activated is more than 10 microgram per kg per minute. Then the next drug which you have to learn here is dobutamine. See, this dobutamine has predominant action on beta 2 receptors. Okay, so what is it used? It is the drug of choice in cardiogenic shock normally. See, dobutamine is the drug of choice for normal cardiogenic shock, but if it is associated with renal failure, oliguric renal, if it is associated with oliguric renal failure, then you should give dopamine, or else normally you can give dobutamine in normal cases. Okay, it is also drug of choice in stress echocardiography. In stress echocardiography, this dobutamine is the drug of choice. Okay, then the next drug which is important is about phenoldiazepam. We have something called as phenoldiazepam. This phenoldiazepam activates D1 receptors and thus increases the renal blood flow. Okay, this D1 causes vasodilatation, increasing renal blood flow, and finally, because of this vasodilatation, it will decrease the BP also. Okay, this phenoldiazepam, what is its use? It is used in hypertensive emergency, and it is used in renal failure also. It is used in hypertensive emergency and renal failure. So this is about phenoldiazepam. Then, so the last thing here is about the summary. So if you see anaphylactic shock, what do you give in anaphylactic shock? In anaphylactic shock, you give adrenaline, that is 1 in 1000 IM you give, that is 0.5 ml, followed by, you will have to repeat the dose if there is no effect, and even if there is no effect, then you will have to give 1 in 10,000 solution in IV. Okay, that is anaphylactic shock. Then in septic shock, you give epinephrine. Okay, so sorry, in septic shock you give noradrenaline. Okay, noradrenaline you give. Then if there is cardiogenic shock, normally you give dobutamine. Okay, if this cardiogenic shock is associated with oliguric renal failure, then you give dopamine. Okay, then what is the next type of shock? If there is neurogenic shock, neurogenic shock is obviously, why is this present? It is due to acetylcholine, so opposite, you should give phenylephrine in neurogenic shock. If there is any vasovagal shock, sorry, in neurogenic shock you should give phenylephrine. In vasovagal shock, vasovagus is a parasympathetic nervous system, and in this case you should give atropine, should be given in this case in vasovagal shock. Okay, so these are the main things. And then this table is asked many times. So if you see, we have the main thing here is, we have for blood pressure, you can have systolic blood pressure and you have diastolic blood pressure. Similarly, you have heart rate, and in the heart rate you have direct heart rate, or you have reflex action of heart rate, and you have net heart rate. Okay, so this systolic blood pressure, as I have already said, it is based on alpha 1, whereas systolic blood pressure is based on beta 1, and diastolic blood pressure is based on alpha 1 and beta 2. Direct heart rate is based on beta 1. So if you give epinephrine, as I have said, it has action on all the receptors, alpha 2, beta 2, alpha 1 and beta 1. So as a result, in systolic blood pressure, it increases the systolic blood pressure. Diastolic blood pressure, it has no effect on diastolic blood pressure because of opposite effects, like because as alpha 1 increases the heart blood pressure, whereas beta 2 decreases the decreases the diastolic blood pressure. So both these cancel with each other and there is no action. Whereas in heart rate, beta 1 increases the heart rate, whereas reflex action is due to diastolic blood pressure. Here there is no diastolic blood pressure, and as a result there is no reflex heart rate, and net heart rate is obviously increased in this situation. Then we have norepinephrine. In the norepinephrine we have alpha 1, alpha 2 and beta 1 action. And here alpha 1, alpha 2, beta 1, systolic blood pressure is obviously increased, and diastolic blood pressure, if you see, the action is on alpha 1 and there is no beta 2 action here, right? There is only alpha 1 action. Alpha 1 causes vasoconstriction and thus increases the diastolic blood pressure. Direct action on beta 1, obviously it increases the heart rate, and there is reflex action because of increase in diastolic blood pressure. There should be decreased heart rate. So because of that, there will be first increase in heart rate and then there is decreased heart rate. So net action here is decreased. Then we have the next drug is isoprenaline. What do you see in isoprenaline? There is only beta 1 and beta 2 action in isoprenaline. There is no alpha action. So because of this, here systolic blood pressure, you have beta 1 action. So this is increased. In diastolic blood pressure, there is alpha and beta 2 and alpha 1 receptors. There is no alpha 1 action. There is only beta 2 action, which is vasodilatation, thus decreasing the BP, diastolic blood pressure. In heart rate, beta 1 action increases the direct increase in heart rate. Reflex action is mainly based on diastolic blood pressure. Here diastolic blood pressure is decreased, so reflex heart rate is decreased. Sorry, is increased, right? Reflex is opposite to that of diastolic blood pressure. So on a whole, there is increase in heart rate. Okay, so this is the important thing. Next, once you have learned about this, now coming to the non-catecholamines. There are some non-catecholamines which are, see, so these non-catecholamines, they can act on alpha 1 or they can act on alpha 2 also. So one of this is phenylephrine. What is this phenylephrine? It is an alpha 1 agonist. And where is this phenylephrine used? Just now we have said that this phenylephrine is used in neurogenic shock. That is one thing. And this phenylephrine has alpha 1 agonistic action. So it acts on eye. So in the eye, because of alpha 1 agonistic action, it contracts the radial muscles and thus causes mydriasis. Okay, whereas in the eye, this phenylephrine also, not only in the eye, in the nose, if you see, it is acts as a, this causes vasoconstriction of the nose and is used as nasal decongestant. Okay, that is phenylephrine. Then we have some more drugs like xylometazoline, and we have oxymetazoline. We have xylometazoline, oxymetazoline, nafazoline. Okay, this xylometazoline, oxymetazoline, and nafazoline, all these are used as nasal decongestants, and they are used for longer time. If they are used for longer time, this will cause something called as rhinitis medicamentosa. These are used in longer time, causing rhinitis medicamentosa. So these are nasal decongestants. Then we have methoxamine or mephentermine. We have methoxamine and mephentermine. Both these will activate alpha 1 receptor, causing vasoconstriction. So as a result, this methoxamine and mephentermine, they are used whenever there is hypotensive cases, we can use them. So they are used in shock without oliguria. If there is no oliguria and in the presence of shock, you can use this methoxamine and mephentermine. Then we have one more drug which is called as midodrine. This midodrine is actually a prodrug. So this midodrine gets converted to desglymmidodrine. This midodrine gets converted to desglymmidodrine. Midodrine gets converted to desglymmidodrine, and it is used in the treatment of orthostatic hypotension. Okay. Then the last drug which is non-catecholamine is phenylpropanolamine. Actually, this phenylpropanolamine, it is actually banned. Why is it banned? The reason for it being banned is because it has an increased risk of hemorrhagic shock. Okay, because of increased risk of hemorrhagic shock, it is banned. Okay, so if you see, we have 5 different drugs, which is phenylephrine. Okay, then we have xylometazoline, oxymetazoline, and nafazoline, which are used as nasal decongestants. Methoxamine and mephentermine are used as hypotensive states and shock without oliguria. Midodrine, which is a prodrug, and it is converted into desglymmidodrine and used in orthostatic hypotension, whereas phenylpropanolamine is banned because of increased risk of hemorrhagic shock. Okay, so these are the different drugs. Next, the last group of drugs which I would like to deal here are specific drugs, right? In the specific drugs, alpha 2 agonists. We have seen about alpha 1 agonists, right? Now we will see about alpha 2 agonists. So the first alpha 2 agonist which I would like to discuss here is clonidine. What is this clonidine? Clonidine is used in the treatment of mild to moderate hypertension. You can use this clonidine, and it is used in opioid withdrawal. You can use this clonidine. It is also used in smoking cessation, opioid withdrawal, smoking cessation, mild to moderate hypertension, in Tourette syndrome, and it is also the drug of choice in diarrhea due to diabetic mellitus, that is diabetic or autonomic neuropathy. You can use this clonidine, and it is also used in post-menopausal hot flushes. In post-menopausal hot flushes, you can use this clonidine, and it is also used in prophylaxis of migraine. You can use this clonidine. Okay, so clonidine has these following uses. Where is it used? Clonidine is used in the treatment of mild to moderate hypertension. It is used in opioid withdrawal, smoking cessation. It is used in the treatment of diarrhea due to diabetic or autonomic neuropathy, post-menopausal hot flushes, and prophylaxis of migraine. So what is the side effect of clonidine? Clonidine side effect is it can cause dry mouth. Okay, it can cause dry mouth. It can cause, because it is used in hypertension, so it can cause rebound hypertension can occur when you stop this. It can cause constipation. Nasal stuffiness is seen as a side effect. Depression is common with clonidine. Dermatitis can occur. Sometimes impotence can occur, and there is increased sodium and water retention is also seen due to this clonidine. So these are the alpha 2 agonist actions, which are clonidine action. It is used in the treatment of mild to moderate hypertension, opioid withdrawal, smoking cessation, Tourette syndrome, drug of choice for diarrhea due to diabetes mellitus and autonomic neuropathy. It is used in postmenopausal females flushes, especially postmenopausal hot flushes. It is used in the prophylaxis of migraine. Side effect like dry mouth, rebound hypertension, constipation, depression, nasal stuffiness, impotence, dermatitis, increased sodium and water retention are seen. This is very important. Okay. The next drug is aprachloridine and brimonidine. See, if you remember, these aprachloridine and brimonidine, these are used in glaucoma. Aprachloridine and brimonidine are used in glaucoma, that too in topical treatment of glaucoma. You can use this aprachloridine and brimonidine. Next we have dexmedetomidine. Okay, this dexmedetomidine is an alpha 2 agonist, and it is used as pre-anesthetic medication. And it is used in pre-anesthetic medication. This dexmedetomidine is used in pre-anesthetic medication. So because it is used in pre-anesthetic medication, it can also be used in the sedation of initially intubated. If a person is already intubated, in them you can use this in the presence of sedation, or in patients who are on mechanical ventilation also you can use it. So it is actually used in the treatment in ICU. Okay, that is dexmedetomidine. Then we have the next group of drugs, which are called as guanfenicin and guanabens. Guanfenicin or guanabens are not used right now. Then we have tizanidine. Where is it tizanidine used? Tizanidine is used as a muscle relaxant. Tizanidine is used as actually a muscle relaxant. Okay. These are the alpha 2 agonists. So what are they? Clonidine, aprachloridine, brimonidine, dexmedetomidine, guanfenicin and guabens and tizanidine. Then after this, the next group of drug is only one drug which is available, which is beta 1 agonist. What is the beta 1 agonist which is available? That is pronaltrenol. Pronaltrenol is the beta 1 agonist which is available. It is actually a noncatecholamine beta 1 agonist which is available, and it is recently promoted for the reversal of beta blocker. For reversal of beta blocker, it has been promoted recently, that is pronaltrenol. Okay. Then the last group of drugs for this class is beta 2 agonists. So what are the beta 2 agonists? Beta 2 agonists include, we have salbutamol, terbutaline, we have salmeterol, formoterol, indocrinol, indacaterol. Okay, we have salbutamol, terbutaline, salmeterol, formoterol, indacaterol. We have ritodrine and isoxsuprine. Okay, so if you see, this salbutamol or terbutaline are actually short acting bronchial agonist. Okay, and these are short acting beta 2 agonist, and these are used as drug of choice in acute attack of asthma. Then this salmeterol, oh yeah, so only salbutamol and terbutaline. Salmeterol, formoterol, and indacrinol, these are long acting beta 2 agonists. Okay, these are used in maintenance therapy in acute asthma. Okay, and this indacrinol, if you see, this indacrinol is actually an ultra long acting beta 2 agonist. Ultra long acting beta 2 agonist is this indacrinol. Okay, this ritodin and isoxsuprine are used as uterine relaxants, and they are used as preterm labor. In preterm labor, they are used as tocolytics. Okay, so these are the different groups of drugs which are important. Then the last drug which is present here is beta 3 agonist. Okay, this beta 3 agonist is mirabegron. What is this mirabegron used? This is a neuter drug. This activates beta 3 receptors on urinary bladder. Okay, so it is used in the treatment of overactive bladder. It is used in the treatment of overactive bladder. So these are all the drugs which you have to learn in sympathomimetic drugs. So thank you guys for watching my lecture. In the next class, we will see sympatholytic drugs. Thank you.